Hello, everyone, and welcome to the Quorum Podcast. This is where academic medicine meets remote, austere, and resource-limited areas.
Welcome back to the program. This is Aebhric O'Kelly. This week, we are again talking with Zach Andrews, who just finished his Master's of Austere Critical Care. We'll talk a bit about his thesis and about his path through the program. Zach, welcome back to the program.
Hey, Aebhric. Thank you for having me on. I appreciate you.
So tell us a bit about yourself and what's keeping you busy.
I have a couple things. I'm still, active duty in the United States Army as a medic there, and work within the training and indoctrine realm of Army medicine. And that ties my hands quite a bit. It's a great job, great place for change, to be at. And then on the other side of that, I work as a critical care paramedic in a rural county of Texas, which I rather enjoy because we have long transport times. It may be hour and a half to get to a reasonable hospital. And so that's been my hobby, which is funny because my coworkers are like, this is my job, but I use that as my fun time, honestly.
Nice. How many shifts do you get in a month?
Right now, I'm working 2 shifts, but they're 48-hour shifts. So 2 48-hour shifts a month, which ends up being a decent amount of time being on a truck and seeing patients.
So obviously, there's a bed in there somewhere, right? You're working out of a clinic and you get sleep.
Yeah, we do. We do. There's a bed. Essentially, there's a house that we stay in. There's a kitchen to cook. There's bunks to be in. And then it is on rotation. Sometimes that rotation means everybody's out, but at least you get a little bit of sleep within there. Throughout the day, those who are wise will get sleep when they can.
How many calls are you getting in a 24-hour period?
It can depend. A slow day, you're looking at 2 to 3, and one of the busier days, you may be at 6 or 7. But when you get to 6 or 7 with the amount of driving time that you have to do, that eats up almost the entire 24 hours.
What's a very long commute time that you've had to do recently?
Oh, I think we went to the far side of the county, at least for a 911 call, an emergency call. And it was an hour and 15 minutes to get to a reasonable hospital. They needed to see a neurospecialist, and so that took some time. And then if we do some of our critical care transports, a lot of hospitals in rural Texas will call us and we'll go pick up their patients. And at that time, it can be 3-4 hours with a patient.
Does your county have a HEMS system?
They do have a HEMS system. Well, maybe not the county in itself, but the area does have one, and they will employ them if they can. But there's so many patients in rural Texas, and they just can't quite get to them all. So they are left for the worst ones. But with a lot of these patients, by the time we get there and HIMS gets spun up and out there, I know there was one call that there was a multiple vehicle collision in rural Texas, and they had 4 patients. In the first paramedic on scene that was able to transport, that didn't take incident command, he actually ended up beating the helicopter back to the hospital by about 5 minutes. And so even though there's HIMS, sometimes that response time doesn't quite work out the best. Now, of course, the helicopter for that was a great asset because that second patient, was just a few minutes behind there receiving at the same hospital.
Tom Mallinson in northern Scotland made a lot of people angry when he did a publication showing that parts of the map is far faster to call an ambulance and transport by ambulance instead of HEMS.
Yeah, I think that's a misconception that people have, that there's a helicopter that's always ready with all the right equipment, ready to go anywhere at any time. But, that it's just not quite the truth. And then when you start looking at, especially the rural parts of the United States, they get quite spread out, and they have to be very careful when they utilize that resource, because once it's in use, it's in use. And so, In South Texas, it's called STRAC. It's South Texas Regional Advisory Command, and they watch the resources very closely to make sure that we don't make poor choices and set us up for failure if something happens.
When I've been on the HEMS in Budapest, they have 911 calls, or they call 112. So the HEMS will respond to a 112 call if it's far enough out where an ambulance is just not going to get there quickly enough.
Yeah, interesting. Yeah, and I could see that for sure. I think we're right on that cusp where it starts to become a game of can we beat them or not. But I think further west than us, it's very likely. And in my county that I work in, we have a regional hospital, but it's a level 4 hospital. I mean, it many times has one physician in it, and usually don't take patients there if there's anything very serious with them. And so we'll drive it all the way in, but the county is even further from us. They definitely have a bit more of a dilemma within that, and they probably use HIMSS a bit more than we do.
Yeah, that is definitely rural if you're in a hospital and you're the only doc.
Yeah, yes, it is.
So, Zach, you have finished your master's in Austere Critical Care. So tell us how it went for you. Tell us what were you studying and what was your thesis topic?
Yeah, so it was it went really well. At first, it was a bit difficult, in the sense of European schools run education a bit differently. Everything's very spoon-fed in the United States. You're going to read these things, be tested on these things, and very easy to get along with that. And with the college, it's my understanding is this is how Europe runs, and it really gives you a lot more latitude to kind of find yourself lost in the material. And not in a negative way, in the same way that one would be lost in a good book. And that's really was fantastic for me because I didn't finish my degree, the fastest by any means, but it allowed me to fully explore topics. Kind of when I felt satiated, I could go, okay, I'm going to finish this and, do my final exam and my paper, and then I'm going to move on to the next class. And so that I really appreciated because I could deep dive into a topic, and especially the ones I really cared about. I was always drawn to uh, ventilation management and hemodynamics. And so I think the second class, the paper focused on ventilation, and I spent a lot of time, way more than I probably should have. I appreciate Dr. Gara for being patient with me during that class. And so that was great. And what that kind of led me into, it was talking about the hemodynamics of a ventilator and the effects of it. And that was wonderful. Deep dove into it, and that started to bring me into my thesis topic. And it was pretty early on in the program. I knew that we had to do a thesis. It scared the daylights out of me because I'd never written anything near that long. I've not written anything a quarter that long, honestly. And so one thing I learned about was the microcirculation, and that was really interesting topic. I've heard about it, but didn't fully appreciate everything that was within there. And so as I deep dove during that class, I knew this. Okay, this is going to be my topic. There's got to be some room in here for me to figure out what to write on. And so what I wrote on was detecting microcirculatory incoherence in a resource-limited environment. And the goal of that is, as I was reading, I saw all these fancy equipment, near-infrared spectrometry, dark field imaging, all these things that seemed mobile to those in a hospital in the sense of you could move it from one patient to another and it's not that big. But it was extremely expensive, and even in hospitals, it's not widely used. Really, only in research institutions, the major ones, is it used. And I saw the significance of microcirculation and how important that is within our patients. And so I started researching into, okay, well, is there anything we can do to actually detect this if we don't have all this equipment? And sure enough, there's quite a few things we can do. It may not be as definitive, but it paints a pretty good picture.
So the microcirculatory options, is there anything for austere environments? You said there's a lot of hospital-based equipment, but how would you assess that in an austere environment?
Yeah, so there's no real device that will make it or translate well to an austere environment. It's just what they have just isn't going to work well. One of the metrics that they had used back in the past was just measuring lactate. And so if you had something like an iStat or something like that, that could tell you if there's poor tissue perfusion, but still at the same time, many of those things they're expensive. They have to be maintained. Cartridges have to be refrigerated, and so that really wasn't kind of scratching my itch for something that was viable. And so looking into it, there were quite a few things that existed. The 5 that I put into my thesis was looking at capillary refill time, perfusion index, temperature gradient, and mottling score, and the 5th one being urine output. And so I threw in urine output as the last one because the prolonged field care, prolonged care world, I mean, that's really what everyone talks about. If you have urine, your patient is perfusing. And in my thesis, I came to the conclusion that it can be a good indicator, but there's so many variables with the kidneys that it's not the most reliable indicator. And so, I really recommend sticking with capillary refill time, perfusion index, temperature gradient, and mottling score. And those have pretty good data behind them in correlation. Many of the studies that they've been studied against correlate with lactate or correlate with other, near field infrared spectrometry, things like that they've been measured with. And so there's some good data that's in there. So they may not be perfect, but I think you can make some pretty solid clinical decisions based on those.
So did you think about making some sort of scoring system like News or News 2 have scoring systems for parameters? And you've stated 5 parameters that you're using for your microcirculatory index. Is there something that you could invent that would address all 5 of those variables?
Yeah, and so I ended up building a microcirculatory integrated severity scale. And I didn't include urine output. And I just didn't include urine output because there's too many variables. When I was trying to evaluate this across, a few patients and scenarios, it would throw off the score a bit. And so I used capillary refill, perfusion index, temperature gradient, and mottling score. And I gave a grade for each of them, a grade of 0 or a grade up to 3, depending on severity. An example of that is capillary refill. If it was under 2 seconds, it got a grade of 0 for normal. And if it got greater than 4 seconds, it was severe abnormality. And the total score of that was a total score of 0 to 4 is likely adequate microcirculation. Still needs to be reassessed every 4 to 8 hours, but it's likely it's adequate. A score of 5 to 8, that's moderate concern. You need to consider interventions at that point, whether it be fluids or whether that's crystalloids or blood products, and possibly the use of vasopressors. And you need to start giving that some more attention, checking that every few hours. And then at a score of 9 and above, that was high risk for microcirculatory shock, which needed immediate interventions and needed to be checked, probably hourly is what I came to the conclusion with on those.
So what would it take for you to provide an educational intervention somewhere and validate this concept?
Oh, yeah. I think to validate this concept, I would need to go to a institution that studied NIRS or dark field spectrometry for microcirculation. And as long as they were doing that, I could come up behind the patients that they were checking and just check these 4 non-invasive things. Capillary refill time, as we know, is as long as it's done correctly. I think in my review of literature, that's the biggest variable is actually doing it correctly, whether on the thumb or on the sternum, but making sure that it is done in a way that everybody does it the same, holding the same amount of time with the relative amount of pressure. And in my practice of doing this, one thing I learned that we weren't great on is you need to look at a stopwatch. Measuring capillary refill by just looking at your watch is not very accurate. And I could use perfusion index. Perfusion index comes on some pulse oximeters, and so that's very easy to do, very quick, pretty accurate to be able to do. Temperature gradient, one you can do, there's a couple different ways you could do it. You could do toe to cord difference. They do it from the thumb to the forearm as a difference in there. You can use a infrared thermometer to be able to assess that. And then lastly is mottling score. Mottling score is great. Very easy to do. Be able to just look at the modeling of the skin starting on the knee of the patient. 0 being there's no skin modeling. 1 is about a quarter size. And then that actually grows almost in the way that we would look at cellulitis on a leg. You'll have somewhat of a defined line of demarcation like that. And it will travel up the thigh. And that's actually how you measure it. And once it essentially reaches the inguinal crease, that ends up being a modeling score of 5. And modeling score of 5 is significantly correlative with poor outcomes in patients, very high mortality within those. And so it's very, very easy to look at and to be able to monitor and track. And you can almost track it like you are with, like I said, cellulitis, using a skin marker and just marking where that's grown from or where it's shrunk to. If you're doing good interventions, you can reverse that. So that's how I would do if I was going to run a study to validate this, is I would partner with one of those institutions and just come behind and then compare data at the end and see how likely or how closely did we resemble each other. Was there a difference for whatever caused the incoherence, whatever that pathology is? Is there a difference for gender or for age of patient, whether young or old? Are there any extremes that this doesn't work with? But overall, I have the suspicion that it probably works across the spectrum pretty well.
So that study would be easier to get an IRB approval if it's retrospective. You're only looking at patient charts and then using was it the AMSS, the Andrews Microcirculation Severity Score, and see if it works.
Yeah. Yeah, we could do that. The part of the problem with doing retrospective is capillary refill time may be the one that is gathered, but perfusion index, temperature gradient, modeling score is likely not gathered at any hospital. And that's part of the issues is even in hospitals, they greatly favor looking at the macrocirculatory parameters versus looking at microcirculation. And that's why microcirculation has kind of become a bit more of a hot topic within the critical care community, as they started to realize, we need to take a better look into microcirculation because microcirculation is where you have the exchange of nutrients, and the macrocirculation is really just the highways, if you will. But that microcirculation, that's the neighborhood roads, and if it's not flowing well there, then nobody's getting home at that point. And so all those things of blood pressure, MAP, and looking at stroke volume, cardiac output, all those are macrocirculatory parameters. And we're needing to take a look. And what they will look at in the hospital really is lactate. They're going to look at lactate and say, well, something isn't going right. I think that's fine. I think that works, but I think it's also something that we could track much closer by doing non-invasive measurements like in my severity score.
So you are interested in finding some location where you could teach either paramedics or the clinical medical officers in Tanzania how to do your AMSS and then follow up to see how accurate and valid this concept is.
Absolutely. Yeah, that'd be wonderful to do. I think couple reasons. One, obviously, you want to test your work that you've done. I feel confident in it, but I do want to test it. But two, I think it could have a significant amount of change for those very rural systems. Those low middle income countries, I think this could play a significant part into their ability to treat various forms of shock patients, think across the spectrum, and to be able to provide that better care, not be surprised as they continue to decline because the macrocirculation looks well, but to be able to realize that the tissue perfusion isn't great. And once that's done, they can start to attack the problems of what's causing that microcirculatory incoherence.
So where did you publish this?
Well, I'm in the process of publishing this. I am working with the physician out of the Institute of Surgical Research here. Ironically enough, he studies microcirculation. And so I sent him my thesis and I said, "Hey, I'd love some. Well, one, your thoughts. You're a subject matter expert, physician in the hospital studying this. But two, for publication, what he thinks the best route of publication is." And so we've been working back and forth. He loved my thesis. He thought it was great. He really appreciated the austere mindset that I took within this. And then he's given me some advice to, his recommendation was actually to break my thesis up into a couple papers and get it published in some pretty decent publications and stuff like that. And so he's excited with it. And he's just kind of helping me guide through the process. Really, the hard part now is how to break up your thesis into 4 pieces and make it still seem like one cohesive work.
Yeah, I was thinking JSON, but no, it's better than this. You look at something like circulation, which has a huge impact factor. This is much bigger than just the soft community. As much as you and I are both very passionate about it, that this knowledge, this paper needs to go higher up to reach a broader audience.
Yeah, and that's my thoughts behind it. And that's also why I chose not to present this at SOMA. A couple reasons behind that is with the medics that are there, because SOMA's medic forward, I don't want them to dig themselves into a hole prioritizing microcirculation when there are, of course, things that come first. Our primary survey and those treatments always come first. This is a little bit further down there before we're going to start treating microcirculation incoherence. And I don't know how much of the audience it would really resonate with. And so looking at this, I thought, no, I need to look for the right audience that this is going to be useful for and can be something that they can employ within their practice.
Once you have this accepted in a big like journal circulation, then you could present in 2027 at SOMA and say, "Hey, this is what I've published." And then you can use the AMSS score as part of your prolonged field care concepts, not march, not pause, not your immediate assessment, but for prolonged care.
Yeah, and I think that's perfect. I think that would align well.
I'm trying to think of where that would plug into Hitman or sheep vomit. Probably Hitman. Sheep vomit's just nursing care, in all fairness. That's something that we should look into. The AMSS score. So Zach, what's next for you? You've finished your master's degree. You've done a deep dive in your AMSS concept. What's next?
Yeah, I have a few things next. I'm close to my retirement in the Army. So, the next 2 years, I'm going to be moving on with, looking for other things to be fun and keep me in interesting forms of medicine. And this next year, I'll start my doctorate through COROM, which I'm excited about. And so maybe this is the research project that I will use at the end. That would be nice to tie it together. Other than that, I'll still be working for rural EMS on the side. I really enjoy doing that and being able to deal with patients, for these fairly sick patients for long rides. I think we do a very good job of mitigating distance, and that's been fun for me. And then on the other side, I'll do some teaching, likely within the special operations community, and just teaching some medicine and trying to stay in the loop and keep progressing that side of the house.
So you're going to be teaching at the schoolhouse.
I don't know if I'll be at the schoolhouse, probably more with contractors.
So yeah, when you retire, there always is an option to go right back and teach at the schoolhouse. But it looks like you have some things set up for more contractual work.
Yeah, the schoolhouse is great. They do a great job. It's get a little bit for me, want a little bit more variety within, my day-to-day change of scenery of where I'm teaching and who I'm teaching and what their exact needs are. And then patient care is just really important to me also. It's just one of those things I've really tried to stay rooted and grounded in. And when you go to the schoolhouse, that can become difficult. Your 9 to 5 is there at the schoolhouse. And so if you want to do patient care, likely you'll have to do it on the weekends and, use up that time for it.
Yeah, no doubt. Well, I'm happy to hear that. And of course, with patient contact, you can test out your severity score.
Exactly. And actually, I have, with my patients, outside of temperature gradient, I need to get that. It's a bit hard right now because it's cold outside, and that's one of the downfalls of the non-invasive forms, the non-technological forms of microcirculation is the weather. But I still I put my pulse ox on for perfusion index. I get a good capillary refill on my patients. I look for a mottling score on my patients. And if I can, I try to get temperature gradient on them. But like I said, right now it's a bit cold, so that's thrown a bit off by it. That's something I currently try to employ and notice these things with it. Be able to make sure that when I take them to a facility and give them handoff, that they understand what these values are and what's going on, what has changed and what hasn't, and just to be able to make sure that the patient gets the best possible care that they can as early as they can.
Zach, I wanted to personally thank you and give you appreciation for what happened when you came to Malta. We were doing the wound vac, the improvised wound vac, and is something I've been struggling with to find ways to get the precise negative pressure. And it was you that came up with a concept of the U-shape IV line or oxygen tubing. I forgot which one we used that had fluid in it. And then you were able to get a column of water to prove that we were in fact doing 180 millimeters of mercury suction on this wound vac. You broke that problem. You fixed it. You found a way to confirm that my hypothesis of an improvised wound vac was in fact valid.
Yeah, that was one. That course was amazing. That was a great time being able to go in that course. And yeah, you brought up the problem of the wound vac, and it just kind of popped in my head, and we sat there and we played with it and went back and forth, and we're able to say, yeah, I think we can be accurate with this. We don't need expensive machinery to do this. And so, I had some of the concept, but it was really, I guess I had some of the way to figure it out, but the concept was yours. And so I appreciate that. I appreciate, being able to help me through it too. It wasn't only me sitting there in the corner doing it on my own, but I remember you and trying to think who else was there.
Laszlo Hegedus, he's the Hungarian guy that's really good at improvised.
Yeah, and so we were over there being able to work through it. So that was fun. I'm glad that became something that was useful to you. It was a fun exercise, honestly. I really appreciated that within the course to critically think and to apply that in an austere setting for when you don't have the resources. That's that's a lesson that we really don't practice. You're forced to do it, and the first time you have to do it is very cumbersome. And so I thought that was one of the best pieces that I got out of the course. I thought that was wonderful.
The eye care course, the 5-day intensive care for austere remote environments, that's one of my favorite to teach. I learn every time we run it. I'm watching you as students coming through who are all practitioners. Everyone has years and years of experience. And I get to sit back and watch how you guys approach a topic, a problem set. And then I learn and I quickly document. I'm in the back of the classroom writing things down as Chubba and other people out there giving you guys the problems to solve. And it's a fantastic CPD course.
Yeah, that must be a rewarding thing. I think most of my time of instruction is fairly new to the medical world, but you're right. You're an expert teaching experts. And so that melding of different backgrounds and minds and ways of thinking and ways of doing things, I bet is very, very enriching in its own.
Zach Andrews, my final question for you is this. What advice do you have for the new medic, the new nurse, the new doc who is just starting out on their career in austere medicine?
Stick to the basics. Master those basics. I will steal a quote from one of my friends. He says that, everyone wants to be brilliant at the fancy stuff, but nobody wants to be brilliant at the basics. And we got to be brilliant at the basics. And that is basic procedures, basic assessments, basic treatments. Do those. Those are your primary things. Do those, get good at them, get comfortable with them, get practice with them. You can practice them even if you're working in a hospital. You can still do those assessments, whether they go to a CT or X-ray or not. And if you do that, that will get you out of the weeds on a lot of your patients instead of trying to go to the fancy, the complicated for everything.
That's good advice. It's been lovely watching you go through our Masters of Austere Critical Care program to see how you tackled each problem set. And I'm looking forward to seeing what you do in our doctoral program.
Yeah, thank you very much. I'm very much looking forward to it too. It's going to be a great experience, and I look forward to starting it.
This has been a presentation from the College of Remote and Offshore Medicine. If you would like to earn CPD credits for this podcast, you can join the Council of Members. Being a member of the college gives you free CPD credit, free access to our virtual field guide, and discounts on our e-learning courses. You can join the team on our college website at quorum.edu.mt.